Hi, everyone, and welcome to the Melanoma Research Foundation's Ask the Expert series. My name is Amy Marbaugh, the MRF's Senior Education Officer. We're thrilled to have you join us today for this wonderful educational opportunity entitled Updates to Frontline Therapies for Cutaneous Melanoma and How LAG3 Treatments Will Impact Treatments. Education is critical for patients making informed decisions about their care. We're grateful to all of our industry partners for their generous support of our education initiatives and investment in the MRF's mission. A brief medical disclaimer before we get started today. We encourage you to use the Q&A box to ask questions throughout the session. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit our website at melanoma.org to learn more about the resources we have available. Also, this session will be available after as part of our video library that you can share with others. Today, we are joined by Dr. Jason Luke. Dr. Luke is the Director of Immunotherapy and Drug Development and Drug Development Center of UPMC Hillman Cancer Center and Associate Professor of Medicine at the University of Pittsburgh. Dr. Luke is widely recognized in the management of cutaneous malignancies, particularly melanoma. Dr. Luke's translational research is focused on application of large-scale informatics to advance cancer immunotherapy, and he has been a lead investigator for clinical trials of numerous novel immunotherapy agents. Dr. Luke has received research support and/or professional awards from the NIH, DoD, ASCO, and multiple professional or private societies. Dr. Luke received his MD from the Rosalind Franklin University of Medicine and Science, and then trained at Boston University Medical Center and Memorial Sloan Kettering Cancer Center. He subsequently has held faculty positions at Dana-Farber Cancer Institute and the University of Chicago. He's the perfect person to be talking and leading this webinar today. Thanks for joining us, Dr. Luke.
So thank you very much for the opportunity to participate today. I'm really excited to talk about LAG3 and kind of where the whole field is going. And I really appreciate everybody in the audience who has taken the time today to join us. Let me just make sure I can set this thing back up the way I had it before so that all of you can see the slides. So we do that, and then we share the screen, and we go like that, and they tell me that you should be able to see the slides. So under the assumption that that is correct, I am going to go ahead and start. So thanks again. So I'm going to give a lecture here for about the next 30 minutes, talking about updates to frontline therapy for cutaneous melanoma and how LAG3 immunotherapies will impact on treatment decisions. And so before I start, I think it's important to put out sort of academic disclosures. You can see that I work with many, if not almost all of the companies that are developing new drugs for cancer, particularly those in the immunotherapy space. And probably the important one here is to note that I am a consultant to Bristol Myers Squibb, who makes the drug Opdualag, which is the reason that we're having this conversation in the first place. And so to start then, let's just level set for maybe some people in the audience who aren't quite the melanoma aficionados yet, which is to understand that the distribution of melanoma across stages is heavily in the early stage disease setting, whereas the number of patients with advanced disease is thankfully relatively small. And all of you will be quite aware of this, that most people that develop melanoma can have it removed by their dermatologist really without much issue. But as melanoma gets increasing depth or grows further down into the skin, people can develop stage 2 melanoma. And as it moves into the lymph nodes, stage 3 melanoma, and then obviously if it spreads in the body, stage 4 melanoma. And you can see the distribution of the percentage of people who have this kind of presentation in the United States on an annual basis. So we're going to talk about the treatment of systemic or metastatic melanoma mostly here. And for those in the audience who have only had to recently start dealing with melanoma, it's worth being aware that about 10 years ago, or a little over 10 years ago, the treatment options for melanoma were really quite limited. And they included chemotherapy, which we hardly ever use anymore, as well as the cytokine interleukin-2, which could only be given to a small group of patients, but was really the first major immunotherapy that we gave for metastatic disease. Now, the landscape is much, much different at this point. So now in 2022, we have a host of different genomically tailored targeted therapies as we describe them. We have immunotherapies of various different flavors, and we even have virus-based therapies with the use of an oncolytic virus that we inject into tumors called TVEC. Now, for the purposes of this talk, we're mostly going to talk about immunotherapies, albeit that some use of targeted therapy is still relevant, although less in the frontline setting. And again, it's important to be aware that the treatment outcomes have changed dramatically in melanoma. So this is dating back to 2010, around the time that we had only these treatments up here. And what you can see is that for patients with metastatic disease that had spread in the body, either to other parts of the skin, to the lung, or to other organs, the outcomes were not good. So this was the survival of patients. You can see basically as a percentage over years. And you can see that, unfortunately, there were very few patients that were living out more than a couple of years. And we're going to talk about how that's changed a lot due to the various different treatments that we now have available. But it isn't really good enough. And what we need to think about now is that while we think about half of patients, even with melanoma that's spread in the body, can do well, that still leaves half where we need to improve the outcomes over time. So in terms of understanding the major categories of treatment for melanoma, they kind of fall into two buckets right now. One are BRAF-directed therapies, and the others are immunotherapies. And just very quickly on the left-hand side, you see a schematic of how cells, and particularly melanoma cells, communicate and grow, where during regular or physiologic conditions, there are receptors on the surface of the cell looking for growth signals like sugars that will activate a pathway, whereas number of proteins will communicate to each other and drive a phosphorylation signal all the way to the nucleus and cause the cell to grow. And in about half of melanomas, this assembly line, as you might think of it, gets disrupted such that one of the proteins gets mutated here at BRAF at V600, such that it's no longer dependent on the upstream characteristics of the cell and just causes the cell to grow. And for that reason, then, developing targeted inhibitors at BRAF and then subsequently at MEK has been quite potent as a therapeutic strategy. Alternatively, immunotherapy is actually the exact opposite from that. Whereas targeted therapy tries to directly kill the cancer cells, with immunotherapy, we're trying to release the immune system to go after the cancer. And on the top, you see a schematic surrounding the drug ipilimumab, which blocks a negative regulatory protein called CTLA4. And very simply, when you turn on an immune response, the natural response of an immune cell is to upregulate CTLA4 and to turn this off. Therefore, by blocking it, we allow immune cells to be more activated over time. And the major breakthrough in cancer immunotherapy, even beyond melanoma, has really been this interaction on the bottom of the PD1 and PDL1 axis. And what we now understand is that in some patients with cancer and most with melanoma, immune cells have come to the tumor and recognize that the cancer is present, but the cancer has thrown up this blocking device called PDL1, and that limits these immune cells. And again, by blocking that interaction with a therapeutic antibody, we can then allow these T cells to sort of wake up and kill the cancer. So all of that is level set when we think about what are the available options for treatment of our patients. And before I go into all the data that underpins how we think about choosing which treatment is the best, I thought it would be useful to throw this up on the screen. And this is actually from the Melanoma Research Foundation's materials surrounding clinical trial participation for patients. And it's really important to note that we only improve the treatment options for all of our patients, including potentially those people that you know, through volunteers who participate in clinical trials. And based on that voluntary participation, you can see that the number of people who are expected to pass away from melanoma has actually dropped substantially over the last few years. And again, we're going to talk about the data to underpin that, but I can't emphasize it enough how much we need people to continue to participate in clinical trials in order to drive the next generation of therapeutic breakthroughs. And so quickly then, our different categories of therapies include targeted therapies and immunotherapies, as I talked about. And we now have quite mature data about the long-term outcomes of patients who get these kinds of treatments. And so on the upper left, you see the combination of dabrafenib and trametinib, a BRAF and MEK inhibitor therapy, where you can see the sort of percentage alive of patients over time going out over several years. And you can see with this targeted therapy, it's very effective at first. Very few patients are having trouble, albeit that starts to slope down over a long period of time, such that about a third of patients are still alive at 5 years. And that contrasts with the immunotherapies, where on the right-hand side in this red line, you see the data for pembrolizumab, where at 5 years, 38.7 or about 39% of patients are still alive. Whereas with the combination of nivolumab and ipilimumab together, you see that 52% of patients are still alive at 5 years. And so these are individual clinical trials, and we always get scolded for commenting and comparing them across each other. But I think this gives you a hint of how we might think about prioritizing treatment options for patients who are facing metastatic melanoma that's spread in the body. Now, when we think about these different treatments, one of the ways, so given there are multiple of them, how might we consider which treatment is going to be best for which patient? And we have some evidence to this from these clinical trials, and we sometimes refer to these factors as biomarkers that might help us choose which treatment is better for which patient. And so some observations from some of these clinical trials. What you see here are the Kaplan-Meier survival plots of how long patients did well over months from patients who received ipilimumab plus nivolumab as compared to nivolumab alone. And what you observe is that in patients with PD-L1 positive tumors, there's actually no real difference between patients who get nivolumab or get the combination together, both obviously better than ipilimumab alone. Whereas in PD-L1 negative tumors, that's where we see actually most benefit for the combination of nivolumab and ipilimumab relative to just taking nivolumab alone. And so in these PD-L1 negative tumors, the combination really looks to be beneficial. And you got to remember that because that'll be relevant when we talk about LAG3 a little bit later on. Now, similarly, what about integrating these data for the targeted therapy with BRAF inhibitors as compared to these immunotherapies? And an important observation from the clinical trials was that there was a disproportionate benefit to the combination immunotherapy in those patients who had BRAF mutations, such that you see in this yellow line that in the BRAF mutant patients, the combination of immunotherapy was better than the one immunotherapy alone. And in fact, in the non-BRAF mutant patients, there actually was no difference there between those treatments with combination versus monotherapy. And again, this is important when we might think about, should we choose targeted therapy or immunotherapy as our first line treatment? And a clinical trial has now read out that actually tested that question. And so this was a clinical trial called EA6134, or the DREAM-seq trial. And very simply, patients either got combination immunotherapy first and then combination targeted therapy if this didn't work, or vice versa, targeted therapy and then combination immunotherapy. And they got randomized 1-to-1. And you can see the schema here. Again, very simple clinical trial, just testing what would we do in clinical practice. And you will not be surprised to hear, based on what I've already told you, that there was a substantial improvement in the outcomes for patients who got immunotherapy first before getting targeted therapy. And so this data has now really changed the way most of us in the field think, such that it's no longer considered a standard of care approach to give targeted therapy with BRAF inhibitors before giving immunotherapies. Now, there are rare circumstances for individual patients where that might be something you'd want to think about, but broadly speaking, in advanced melanoma, we give immunotherapy first. And that wasn't the only clinical trial that showed that. There was also a clinical trial in Europe, which has this somewhat crazy name called the Succumbit trial. And it was a rather complicated study where patients either got targeted therapy, then immunotherapy in blue, or they got some version of immunotherapy early, followed by targeted therapy. And what you can see on this survival plot is that the two arms that got immunotherapy first both did better than the arm that got targeted therapy. So this is consistent with that previous clinical trial, again, emphasizing the patient should get combination immunotherapy before targeted therapy for advanced melanoma. Now, there's been some interest in saying, well, if there's a benefit to both kinds of treatments, wouldn't we want to think about giving all the drugs maybe at once, sort of triplet with targeted therapy and immunotherapy at the same time? And 3 different clinical trials have now tested this out. And I'm going to show you the results from 2 of them, which sort of on a first pass looks sort of interesting. So this was a clinical trial called Inspire 150, which combined vemurafenib, cobimetinib, and atezolizumab. You don't have to remember all those, but BRAF, MEK, and PD-L1. And that looked like it was better than giving just the BRAF inhibitor drugs alone, albeit that was for progression-free survival, or how long did it take initially before melanoma started to grow again. Unfortunately, there did not look to be much of a difference in terms of the long-term survival outcomes of the patients who got that treatment. And so this treatment was actually approved by the FDA, but I'll say frankly, almost nobody uses it. And that's in contrast with another clinical trial of some different drugs, but conceptually the same idea, dabrafenib, trametinib, and spartalizumab, which also looked to be a moderate improvement, but then really didn't look much different for overall survival. And this combination did not get approved. So while this is available as a treatment, very few doctors recommend this because it's kind of unclear how much of a benefit there really is. And unfortunately, there are a lot of side effects of giving those drugs together. And I won't go over this whole table of numbers here, but the take-home point is that treatment-related adverse events of any grade or of any quality were 80% for high-grade events. So significant side effects happened in 80% of patients on both of those clinical trials of targeted therapy with immunotherapy that I just mentioned. And that really, to me, is not so attractive, given that the benefit is a little bit unclear relative to other treatments that we might have. So just to summarize quick then, the state of the field is such that we now think that giving immunotherapy first is generally preferred to giving targeted therapy, and that giving targeted therapy and immunotherapy at the same time does not really look like a great idea because it causes a lot of side effects and isn't necessarily more effective than we would otherwise be. And so that sets up our discussion around LAG3. So what is LAG3? Well, I told you before about this interaction of PD1 on immune cells that have come and found the tumor, and how if PD1 binds to PD-L1, that blocks these immune cells from being effective. And we know that drugs like nivolumab, which bind to PD1, can interrupt this interaction and allow these immune cells to be more effective. Well, it turns out there are a number of other receptors on these immune cells, which we refer to as exhausted T cells, which can have similar effects. And what you see in this cartoon in the middle of the screen is this immune cell showing both PD1 and LAG3 coming in contact with the tumor, but now being treated with nivolumab to block PD1, like I talked about, as well as a new medicine called relatlimab, or RELA for short, which blocks LAG3 and disrupts its interaction with some other molecules that we think are important, one of them being the major histocompatibility complex 2. Again, you don't have to remember that, MHC2. Small, just to summarize it, nivolumab then and relatlimab given at the same time to block PD1 and LAG3 as a new treatment modality to reinvigorate these immune cells in order to kill the cancer. And so just as a step back quickly to better sort of fill out your understanding of the immunology that underpins these kinds of treatments, it's important to be aware that these molecules that I'm talking about, PD1 and LAG3, are normal molecules, natural molecules in your body that your immune system uses so as to not go out of control and cause autoimmune-like problems. If you ever heard of lupus or rheumatoid arthritis, those kinds of things, those conditions happen because our own immune cells kind of get messed up and start attacking our own body. It's now well understood, and has been for a while, that our immune cells can come in contact with bad stuff in the body. And just for short, we'll call those antigens, and they might be from like a virus or a bacteria, or possibly from a cancer cell. And the natural response is to kill whatever cell is showing those bad molecules, because presumably it's infected or it's a cancer or something. And if your immune system is able to do that, your immune system will remember, because these effector T cells that killed the bad cells will actually go into a memory state so that they can be woken up later. And most of you will know about this, obviously, because in the context of COVID-19, this has become a big deal, the vaccine and everything else that goes along with that. Unfortunately, if your immune cells come in and are not able to get rid of the problematic cells or these antigens that I'm talking about, the immune cells will slowly kind of start to shut themselves off. And the reason is because the natural reaction of our body is to slow this process down under the possibility that it could be the case that our immune cells are just overactive and we don't want them trying to kill ourselves. Okay, so people who have arthritis will have this problem. And our natural body's reaction is to shut these immune cells down so they don't continue to cause damage in our body. And we can measure that by the expression of various different molecules, which are shown over here, but you don't really have to pay attention to. The important point is that increasing dysfunction of immune cells is associated with the expression of these same molecules I was just telling you about. So as these immune cells become a little bit messed up, they show this molecule called PD1. As they get more messed up, they can express this molecule called LAG3, and so on and so forth with more and more of these molecules, which is really the rationale for why we might want to give more than one drug that blocks these negative regulatory receptors in the hopes you can push this whole process back up the hill and get these immune cells more active again, hopefully then to fight cancer. Let's get that part. And so that all led up to this clinical trial that's known as Relativity 047, which was a global randomized double-blind phase 2/3 clinical trial where patients who had unresectable or metastatic melanoma that had never had treatment before and who were otherwise pretty healthy were randomized 1-to-1 to either get nivolumab, which would be considered the standard at that time, or to get nivolumab plus relatlimab given as a single drug all in one infusion. And you can see that 714 patients participated in this global clinical trial. And the endpoint of the clinical trial was to see which arm would show the longest period of time keeping melanoma from growing back. And secondarily, they wanted to look at how long people survived and how much did the cancer actually shrink. And we call that best overall response. And so these data have been released now, over a year ago, showing that the combination of nivolumab and relatlimab had a major impact, more than doubling the amount of time it takes before melanoma starts to grow again, also known as progression-free survival, compared with nivolumab alone. And again, looking at these plots, we call them Kaplan-Meier survival analysis. The progression-free survival, you can see, is better for the blue line, which is nivo plus rela, compared to the green line, which is nivolumab alone. In the context of how long patients lived, it also appears preliminarily that nivolumab and relatlimab together improve the amount of time that patients lived relative to nivolumab alone. And due to some specifics around the statistical design of the clinical trial, this p-value number didn't quite meet its pre-specified threshold. But if you look at these numbers, it actually does look like there's probably a difference between these two arms of the clinical trial. Again, suggesting that this combination both delays how long it takes before melanoma starts growing again and probably improves the length of time that patients survive after getting the treatment, all compared with nivolumab alone. Finally, when we look at nivo plus rela, we see here that the response rate, or the number of patients that had major shrinkage of the cancer, was 43%, compared with nivolumab alone at 33%, and that is an improvement, a significant improvement as well. It's worth being aware, actually, that I showed you previously the data for combining nivolumab with ipilimumab, and those data also looked impressive relative to nivolumab alone. And if we take an absolute scale, looking at the difference between nivolumab and nivolumab plus relatlimab, these changes in the response rate and in the progression-free survival are actually higher for nivolumab plus relatlimab as compared with the nivolumab plus ipilimumab combo, albeit that they're pretty close. And that'll become relevant because an obvious question then in your mind, I would assume, is, okay, well, if there are two combination immunotherapies, then which one should I take? And the answer to that is maybe, sort of, kind of. And we'll sort of try to explain that in a second. It's going to be different for different patients. And one point in that I think is important to call out relative to what we've already talked about were the pre-specified subgroups within this clinical trial. And you can see there's all kinds of dots and numbers and stuff all over this slide, but we don't need to go over all of them. But I want to call your attention down here to this, the analysis of prior BRAF mutational status. If you'll remember, at the beginning of the talk, I mentioned that nivolumab plus ipilimumab was disproportionately better in patients that have BRAF mutations. And that's part of probably what led to that clinical trial showing it's better to give immunotherapy first before targeted therapy. So in this clinical trial of Nivo plus relatlimab, or LAG3, what we see is actually there isn't much difference between the BRAF mutant and the BRAF wild type groups, with the response rate being roughly speaking similar between those two groups. So there we see a difference between the Nivo-IPI and the Nivo-Rela treatments. So for BRAF mutant patients, I might prefer to offer Nivo plus IPI in a patient who has a BRAF mutation relative to one who does not. Another factor that's worth being cognizant of is this factor called lactate dehydrogenase, which we know is a poor prognostic factor in melanoma. And what we can see is that, as expected, as the LDH number is normal or greater than normal or really high relative to normal, the benefit of the treatment goes down a little bit with the Nivo plus Rela. And that's not a surprise, but it's important to point out that one of the benefits for Nivo plus IPI was that it seemed to be disproportionately active in that same kind of subgroup of elevated LDH at baseline. So again, when we start to think about which patients would we choose for which treatment, in my practice, if a patient had a BRAF mutation or had elevated LDH, I might prefer to still give them Nivo plus IPI as compared to Nivo versus Rela based on this data that we have here so far. Finally, what about side effects? And so this is a really important one to be cognizant of. So for a long time, we've thought about Nivo plus IPI versus Nivo alone. And the consideration was really that Nivo alone didn't cause a lot of side effects, whereas Nivo plus IPI did cause a lot of side effects. So what about now Nivo plus Rela? And this is an earlier analysis, but it sort of shows the same point, which is that when we look at the incidence of high-grade immune events, so the bad side effects that might put somebody in the hospital, for nivolumab alone, about 10%, which is roughly speaking similar to what we've always known about nivolumab. And that was true in both clinical trials. But whereas for Nivo plus IPI, the rate of high-grade side effects is more than 50%, with Nivo plus Rela, it's more like 20%. So while that is an increase from one drug alone, it's less than half of what we saw with Nivo plus IPI. So from my perspective then, the Nivo plus Rela combination, which is called Opdualag for commercial purposes, is very attractive in patients who I would have otherwise have considered to have gotten nivolumab monotherapy or one drug alone. In all those patients, I think my preference would be to give Nivo plus Rela. However, there are patients still where I would want to consider giving Nivo plus IPI, such as those who have a BRAF mutation, those who have elevated LDH, and potentially some other factors that I don't have time to go over just right now. So that is all the context for the treatment of metastatic disease as it stands right now. So first line choice of treatment for patients who have never had any treatment before. But as I wrap up this talk, I wanted to spend just a little bit of time to sort of introduce the idea that it's actually not quite so simple in clinical practice anymore. And these considerations will be even more nuanced, which is to say that at this point, the treatment of patients before they develop metastatic disease is actually quite common and is the standard for patients with stage 3 and some stage 2. And we have done clinical trials to look at targeted therapies, dabrafenib and trametinib, as well as immunotherapies, showing that after surgery, these treatments will reduce the number of patients who have melanoma come back. And therefore, in those patients who unfortunately do have melanoma come back, they will have already had some of the treatments. And how does that impact on which treatment we would choose in terms of being the best one for them in that scenario? And that's a complicated question that we'll sort of touch on a little bit. I just told those curves I showed you were for stage 3 melanoma, which involves lymph nodes. But I would also highlight now that even in patients who do not have involvement of lymph nodes, but rather only deep primary lesions, so stage 2B and 2C melanoma, we now have clinical trial data suggesting that the adjuvant or post-surgical use of immunotherapy improves the number of patients who might have the melanoma eventually come back and spread in the body. So again, emphasizing that the majority of patients over the next few years, or moving forward from now, who develop melanoma will probably have already had treatment with an immunotherapy or a targeted therapy before they have to consider their frontline treatment in the metastatic setting. And so that complicates the interpretation of some of that data that I already showed you, because you'll remember that in those other clinical trials I was talking about, patients had not had any other treatment prior to being treated in those trials. The treatment in the adjuvant setting also does not come without any potential side effects or issues. So in this table from the clinical trial recently reported out for stage 2 melanoma, what you see is that about 20% of patients will have had a side effect that required ongoing supplementation of hormonal treatments, most of which were thyroid events, but some of which were much more significant, with replacement of corticosteroids or even insulin for the case of diabetes. So this is important also because if patients were previously treated, if the treatment didn't work, it's also possible they could be carrying some of the side effects from their prior treatment when they're being considered potentially for combination immunotherapy, and that might impact on treatment choice. Now, this question of should patients be getting treatment in the adjuvant setting then, if we don't know for sure whether or not it's going to make a long-term difference? So if you have melanoma, say, and I'm your doctor, and I say, well, we've taken the melanoma off by surgery, we could give you immunotherapy, but we don't know for sure whether or not it will keep the melanoma from coming back. And we don't know for sure whether or not on average, it would cause more people to live longer, because we now have all these other treatments we could give you at the time the melanoma might come back. And this is a really complicated area for discussion. And my guess is somebody will ask a question about this a little bit later. In the clinical trials that we have in the post-surgical setting now, there's no evidence so far that there's a difference in the long-term survival of patients as to whether or not they get the immunotherapies immediately after surgery or not. But as I've shown you, it's very clear that by giving the treatments right after surgery, we clearly delay the recurrence of melanoma on average in the population. So should we be treating people after surgery or not, considering they could get those side effects that I just showed you, like the thyroid events and other things? And I think this is where an individual patient level decision making is really important. And I don't know the answer to this, and I would defer it to your specific provider to help you work through this. But what I'll note is that from survey data that we've seen from patients and published in reputable journals, there are most patients do choose that they would like to take the treatment after surgery, because the risk of recurrence really does drive a psychological risk over time. But for anybody in the audience who's facing this right now, it's an important question that you really need to talk to your doctor about, because obviously it will have downstream implications in terms of other treatments that you might take. So just briefly, I'm going to go through a couple more things quickly just to level set and tell you what else is going on in the field. And so in this post-surgical setting for stage 2 and stage 3 melanoma, there are a number of clinical trials ongoing to look at immunotherapy as well as targeted therapy. So I showed you one clinical trial already for stage 2, but there are several others that are moving these immunotherapies and targeted therapies into that deep primary setting as well. It's also worth being aware that an adjuvant post-surgical study for the nivolumab plus relatlimab combination is already ongoing, comparing Nivo plus Rela compared with Nivo. And so it's very likely, as I mentioned, that even more patients will be treated in the post-surgical setting moving forward. But what about that question? What do you do if the treatment after surgery didn't work and the melanoma came back anyway? And this is a complicated area, and we don't really know the answer to this just yet. I'm just going to give you very quickly sort of an overview of some of the treatments that we're developing that might be useful to somebody if they're facing that scenario. So one of them is the idea of giving ipilimumab after patients have already gotten anti-PD1 with nivolumab or pembrolizumab and adding it to the anti-PD1 antibody. And so we did a clinical trial some years ago where we did this, and patients who had only gotten one drug went on to get 2 immunotherapies. And what we saw was about a third of the patients, 30%, would have major responses and shrinkage of the tumor, which was quite durable over a long period of time. So for me personally, if patients got adjuvant pembrolizumab or nivolumab and progressed, thinking about adding low-dose ipilimumab on top of that immunotherapy, I think seems very attractive. In addition, there's a new category of treatment under development known as tumor-infiltrating lymphocytes, which is emerging as a potential treatment option and might be approved by the FDA in the coming year. And this is a complicated treatment where the melanoma needs to be removed surgically and then processed to sort of pull out the immune cells, which are then grown up in the laboratory. And then the patient is brought back and has their own immune cells reinfused into them. And when we do this, we can see that response rates or major tumor shrinkage can be observed in upwards of somewhere between about 30 and 40% of patients. It's not entirely clear yet, but that's a pretty useful treatment. And so I mentioned the combo with adding IPI is about 30%. And here we see that these TIL therapies, again, about 30%. There are other options. There are other kinds of cancer drugs known as VEGFR2 TKIs or blood vessel blockers that clinical trials are showing may be quite advantageous for combining with immunotherapy. They seem to have an effect on a number of the different immune cells to make them more potent and to limit the bad effects of cancer-associated angiogenesis or blood vessel growth. And so a trial of lenvatinib plus pembrolizumab has shown a response rate, again, you won't be surprised, in the range of about 30% after patients have already gotten immunotherapy. And a number of clinical trials are ongoing to try to really prove how well this really works. Finally, we have a number of approaches now under development where we directly inject into the melanoma tumor itself different immune stimulants, one of which is something called plasmid interleukin 12 or IL-2. And IL-12, excuse me. IL-12 is a very powerful immune molecule that causes a number of your immune cells to be even more active and turn into immune fighter cells. And the process sort of looks like this, where we stick a needle in and inject the substance and then apply a little bit of electrical signal, which we call an electroporation, which makes the tumor start producing this immune molecule that allows the immune cells to fight the cancer. And I don't have time to go over it, but in some patients, this can cause very robust immune reactions, which can lead to the tumors really shrinking quite dramatically. And this treatment has a little bit of a complicated name. It's called tavakinogene plasmid. You don't really have to remember that, but you can be aware that clinical trials are ongoing to try to prove the benefit of that kind of therapy. Finally, in the injectable space, there are other immune stimulants that we're also studying. One of them is called vidutolimod. And we, again, inject this with a needle directly into the tumor. And what it is a CpGA DNA payload, which is like a really strong immune stimulant that's coated with a structure that sort of looks like a virus. It's not actually a virus, but it sort of looks like that, to really stimulate the immune system and draw it into the melanoma. And then we combine this with immunotherapies like pembrolizumab, as I talked about. And again, upwards of about 25% of patients can really benefit from this kind of a treatment. Finally, just to fill out your understanding of where the field sits, there's a novel technology in the field coming forward where we can actually use parts of immune cells to try to direct the immune system. And one of them is this molecule called tabentafusp. And what it is sort of two different parts of the immune system in one. It's a targeting domain with a T cell receptor that tries to grab particles on cancer cells. And in this case, it's GP100. And on the bottom side is an effector domain, which brings in a targeting molecule to immune cells called an SCFE anti-CD3. So this side grabs the tumor, this side grabs immune cells and pulls them into the tumor. And when we do that, what we can see is, like I mentioned before, this marked in blowing up of the tumor such that you get all these immune cells that come in red compared to the baseline. And this kind of a treatment with tabentafusp is actually already FDA approved in the rare subset of melanomas that arise in the eye, known as uveal melanoma, but it's also being developed for cutaneous melanoma. And the final treatment I would just note is that we talked about the TIL therapy. There's another kind of treatment called TCR transduced T cells. And in this scenario, what we do is take blood out of the patient and then clone into the patient's own immune cells, sort of a homing switch. And we call that a T cell receptor. And so these now TCR engineered T cells can be brought back and being given back to the patient such that they get their own cells back, but that have been gene modified to actually then go after the cancer. And emerging data is suggesting that this looks very promising in melanoma as well. So just to conclude then, We've had rapid progress in systemic management of melanoma. There are a lot of treatments now available, and the therapies are moving into earlier lines of treatment, so in the post-surgical setting. But a lot of unmet need remains around developing the right biomarkers to select which patients, as well as to try to figure out, do we really need to keep treating people for so long? And clinical trials are being designed to try to address that. For patients who have not had any prior treatment, first-line metastatic therapy really now should be either the treatment with nivolumab and relatlimab, which again, I told you is called Opdualag based on the data I showed you. But in some patients who have high-risk disease, I might still consider giving them nivolumab and ipilimumab, which is known as Opdivo and Yervoy. But there are a lot of other agents on the horizon that will continue to expand the treatment options for patients. And this brings us back to what I said before, which is we really still need participation of people who are facing melanoma in the clinical trials so we can develop even more effective therapies over time. So thank you very much for your attention today. And I'm more than happy and very excited to get into the Q&A portion and address your questions. Thank you very much.
Well, thank you, Dr. Luke. That was a marathon of all these exciting treatments that have already been approved and hopefully will be approved, in the next coming years. We do have a few questions, but just to kind of, start it off, just to, hit the nail on the head. So to be clear, Opdualag or Ipi-Nivo in the metastatic setting for patients, which is the better option?
Right. So it's a really good question. And the answer is it depends on which patient is getting the treatment. All right. And so we're very fortunate in melanoma to have a lot of treatment options, but it is quite important that the doctor using the options has a good sense of which patients they might work the best in. So I would say that in my practice, the way that I address that question is for people who have, I don't want to call it run of the mill, but less aggressive looking melanoma, I would consider giving the Opdualag drug, nivolumab plus relatlimab. So that's probably going to be my go-to treatment. And the reason is it looks to be quite effective and it has less side effects than the alternative. But there is a population of patients who have high-risk disease, and we would characterize those as patients probably with BRAF mutations, who have brain metastases, who have elevated lactate dehydrogenase levels, or whose disease is growing very rapidly, where we probably would still prefer to give nivolumab and ipilimumab because our historical data set is the strongest for that treatment. And unfortunately, despite all the progress, melanoma can still be a very terrible disease. And we never want to be in the situation of woulda, coulda, shoulda, and we might have tried something else. We want to feel confident that we gave it our best shot from the beginning.
Thank you for that answer. Someone in the chat, Grace asked if are there going to be any trials that combine Ipi-Nivo and Rela, or a trial that directly compares Ipi-Nivo to Opdualag? Right.
So there are already trials that have looked at the triplet, but those data have not been released to the public yet. And so we don't know exactly what that would look like, but yes, someday we will know that. In terms of comparing the treatments head to head, many in the community are talking about a clinical trial like that. But as obvious as that clinical trial seems, it actually turns out from a statistical perspective that trying to design a clinical trial like that is actually very, very complicated. Because when we compare head to head the outcomes from the different clinical trials, they look so similar that to actually do a statistical test, we would need thousands and thousands of people to participate. And you got to realize that the largest clinical trial in melanoma ever done is only about 1,000 patients. And so if you design a clinical trial that needs 5,000 patients, it's very likely will never actually get done. And this is a difficult thing in clinical medicine, is that there are a lot of good questions we wish we could ask. Sometimes they're not feasible to address. So what I'd say to it is, yes, we want to know that answer. I don't know when exactly we would figure that out, though.
Ed has a couple of questions. Are there any trials looking at relatlimab, Opdivo in brain mets?
Yes, that's a really good question. And absolutely, those kinds of clinical trials are either underway or in development right now. And so we'll get those results probably in the next, I don't know, year to 2 years kind of time frame. I would just really emphasize first, though, that that's in the brain met population. The data for Nivo plus IPI for those patients that don't need steroids really has been transformational. And I would not want people to think about transitioning from Nivo plus IPI in that population until we had very strong data that suggested similar outcomes.
Ed also was wondering, do you use LAG3 staining percentages to guide your decision when deciding between the drugs?
So that's a good question. I didn't dwell on that because LAG3 staining is not a standard of care test. So as a general oncologist, you can't just order up a LAG3 test from your pathology department or from a commercial vendor. From the clinical trials, it does appear that patients whose tumors have higher LAG3 expression do have better outcomes to the Nivo plus Rela combination. But unfortunately, in the context of clinical practice, it's not a test that we really have at our fingertips right now. So the short answer is no, I wouldn't use it. If we had it, would I try to incorporate it? Yeah, probably. And so the question will be over time, does that become more available?
We're hitting you with the hard questions today. Jane has a question. Why do you think that the overall survival is superior in the metastatic setting using immunotherapy versus targeted therapy? Is there a biological mechanism that might be involved?
Well, I think those two kinds of treatments are very, very different. And so the biological reason, I guess I would say, is that in melanoma, and this is different than most other cancer types, the quality of the immune response and the robustness of the immune response is very powerful. So that whereas if you contrast with lung cancer per se, targeted therapies do actually look more potent than immunotherapies. But in melanoma, it's the other way around. We have many more patients with long-term survival on immunotherapy in melanoma. And so I think it's probably the case that, like we said, the BRAF mutant melanomas are disproportionately sensitive to the immunotherapy. And so that gives it even one more leg up, so one more step up. I think the other caveat to this is that one part of targeted therapy that's sort of more like chemotherapy is that when people have side effects, there's a temptation to want to reduce the dose to decrease the side effects. And it's very clear that if you decrease the dose of the targeted therapy with the BRAF and MEK inhibitors, it doesn't work as well. So one of the big complaints about the clinical trial that I showed, the EA6134 DreamSeq clinical trial, was that a lot of the patients in the BRAF arm actually had dose reductions. And those dose reductions were really very much frowned upon in the original trials. But in standard clinical practice, it's pretty common for doctors to reduce the dose. And that unfortunately reduces how well it works. And so that was one thing that I would just note, that in my practice, I almost never reduce the dose of BRAF inhibitors. Sometimes we have to take breaks if patients are having side effects, but I almost always go back to the full dose. And that's probably, those different elements probably explain why there was such a difference between the immunotherapy and the targeted therapy.
Aaron was wondering, where do you see TIL therapy fitting into the sequencing of all of these treatments?
Yeah, all right, Aaron. I'm wondering if Aaron is actually an investor. No, so I think I think it's very promising because one other piece of it, which I didn't dwell on, is that so far from the data that's available about TILs, it appears that they disproportionately work the best in the patients who got the least amount of benefit from other immunotherapies. In other words, people who got Nivo or Pembro and progressed right away, those are the people where the TILs seem to work the best. So that is our highest unmet need population. And so to me, it's very exciting to think we would have a treatment specifically that works the best in the patients where we have the least effective treatment. And so how is that going to integrate into our treatment paradigm? Well, we don't know exactly yet because the TILs have not actually been approved by FDA, and it may make a little bit of a difference what the labeled indication of the TILs actually says. If it's really wide open, my preference would be to try to do the TIL harvest, where we actually do the surgery to get the cancer, probably after the patients progress on their first treatment, whether that's adjuvant therapy or whether that's first-line metastatic therapy. And then we try to get those TILs all ready to go because we'd want to be able to give them as soon as we can thereafter. So to me, the TIL therapy is probably going to slot in as like a second line or a third line treatment. It is rather involved to do the surgery, to make the TILs. You actually have to, I didn't dwell on this, but you have to give the patient chemotherapy before you give the TILs back, and they're in a hospital for a while. So it's a complicated treatment. I don't think it's going to be like the main treatment, but I do think it has a lot of upside, especially for the patients who don't have other treatment options.
Patty has a question. Her daughter is a stage 4 survivor, treated with immunotherapy and had a good response for several years. Unfortunately, the cancer returned with bone mets, first treated with targeted therapy, and then looks like she started immunotherapy. What is the response in bone mets with Nivo-Rela? Is there any data on that yet?
Yes, that's a good question. I'll start by noting that unfortunately, bone mets are one of the harder areas of the body to treat when melanoma decides to go there, and so that's a tough thing. We know that with nivolumab and ipilimumab, relative to other treatments, we can get better responses in bone. From the data that's been disclosed so far from the Nivo-Rela combination, we don't have that granular level of data. So I don't truly know the answer to that. What we know is that as there are more sites of disease, that the combination with Nivo and Rela is less effective, although that's not a surprise. And in liver mets, it's also less effective. But with bones, we don't exactly know the answer yet. But I will say, I guess what I would say is that in a patient who had not had any prior treatment, my preference would be to give somebody with bone mets ipi-nivo. In the scenario that's being described here, where a patient has already had multiple different treatments, that makes it harder. But I would certainly want to make sure that I got ipi-nivo earlier in that kind of a patient and not miss that opportunity, given we know that can be effective, if that makes sense. So if in that patient I was confronted to say, should I give Nivo-Ipi or Nivo-Rela, I'd probably give Ipi-Nivo first. But there are other considerations that probably would be specific to this case, so I can't say exactly.
You talked about, a lot of for patients who have BRAF mutations. What about patients who have other mutations like NRAS? Have they been any clinical trials at looking at NRAS specific treatments, or what might patients look for?
Yeah. So in melanoma, we talk about BRAF a lot because it's the one that we have drugs for. But on a genomic level, we categorize melanoma into 4 categories. One is BRAF. The second one is RAS, and that's usually NRAS. The third one is NF1. And then the fourth one is none of the above, triple wild type. And so we only have targeted therapy for BRAF, but the specific outcomes based on genomics for NRAS, NF1, and for triple wild type are less well understood across the board. There were early data that suggested that NRAS melanoma actually had worse outcomes to immunotherapy with IL-2 and with interleukin-2. Albeit, however, that in the era of PD-1 combination therapies, I don't think that data is very strong. So I think I don't know the answer. I actually think the answer doesn't really exist to the specific question that was asked. But right now, we kind of don't use the genomic classification to decide which treatment to give, except in the case of BRAF. So that's why in clinical trials, we basically say BRAF mutant versus everybody else. And we don't substratify because we don't actually have treatments for the other groups. And so I'm sure someday some of that data will come out, but it'll take several years for academic investigators to aggregate patients treated in their clinics to try to figure out that question.
I have one more question for you. What are you most excited about with all of these new treatment options? What is the most exciting thing to you, or what do you see, what's the most exciting thing coming up maybe in the next 1 to 2 years?
Well, I think that's a tough question. I do early drug development, so I see many compounds come through, and I'm all, raza, like super excited, but also you have to be skeptical because it's a long way from early development to truly getting drugs registered that help a lot of patients. I think the fact that relatlimab is now available is a sea change in terms of the treatment options, but also emphasizes that it's possible that we could make a lot more progress. And I showed you some of the other early phase molecules. The thing that I'm the most excited about it, I guess I would say, is probably the last couple of things that I noted on the slides, which is I think we're starting as a field to better understand the biology and the engineering that it's going to require to actually do what we call adoptive cell transfer at scale. So those are the TILs, those are the TCR transduced T cells, those are the T cell redirection approaches, where we can actually orient our own immune cells to go after the cancer. As we can do that better and in greater groups of patients, to me, that's very, very exciting, because we already know with Nivo plus IPI or Nivo plus Rela, we can put 50% of the patients into long-term durable disease control. The problem is, what about the other 50? And for those, we really need new ideas. And I really think the cell-based therapies could be part of the solution for those patients. So all of these adoptive cell transfer approaches to me are very high upside in patients who have unfortunately had progression on a checkpoint inhibitor combination therapy.
Well, with that, I would like to thank you, Dr. Luke, for joining us today and being part of our Ask the Expert session. Again, this program will be available on demand and will also be streamed on our social media channels. Make sure you visit melanoma.org and follow us on social media. We're on Facebook, Instagram, Twitter, LinkedIn, and TikTok to learn more about our upcoming webinars and all of our other educational opportunities. Thanks for joining us, everyone, and have a good weekend.